What is renal artery stenosis? Renal artery stenosis is a narrowing of the renal artery, either due to atherosclerosis in older patients or due to fibromuscular dysplasia, so abnormal growth of the vessels in younger patients. It can occur on one side, so unilaterally, or on both, called bilaterally, and may remain asymptomatic for a long time. Eventually, it can lead to high blood pressure because the kidney senses reduced perfusion and responds as if blood pressure is too low. How can renal artery stenosis be recognized? There are two main ways to detect renal artery stenosis. High blood pressure is often the first sign, but clinically also an AKI, so acute kidney injury, can result when the stenosis reaches a critical threshold. The stenosis causes rapid blood flow through the narrow segment, which might be heard on auscultation as a bruit over the renal arteries. Duplex ultrasound is the diagnostic method of choice, as it can detect the increased flow velocity in the stenosis by color Doppler. Second, the effects of the stenosis, so the kidney underperfusion, can be observed. Up to about 60% stenosis, the kidney can compensate by dilating the artery distal to the stenosis, so patients are usually asymptomatic until this reserve is exhausted. Beyond this threshold of about 60%, symptoms like blood pressure begin to appear. These symptoms result from an overactivation of the renin-angiotensin aldosterone system, short RAS, which is a form of secondary hyperaldosteronism. If you want to learn more about secondary hyperaldosteronism, check out this video. Angiotensin II and aldosterone lead to high blood pressure, which is a form of secondary hypertension that can be difficult to control. The diastolic blood pressure is particularly elevated due to angiotensin II stimulation, which causes generalized vasoconstriction in the body. And in severe cases, especially when both kidneys are affected, excessive aldosterone may lead to hypokalemia or metabolic alkalosis in the blood. Let's compare atherosclerotic renal artery stenosis and fibromuscular dysplasia. Atherosclerotic renal artery stenosis accounts for about 90% of cases and typically occurs near the origin of the renal artery from the aorta. Why is this? Because this is where turbulent flow is greatest, since blood flow changes its direction. And the more turbulence there is in the blood, the higher the risk of atherosclerosis. The stenosis itself can be visualized best on CT or MR angiography. On CT, atherosclerotic stenosis appears heavily calcified, so white. In contrast, fibromuscular dysplasia is much less common and tends to occur in younger, otherwise healthy patients, with a predilection for young women. It correlates also with collagen diseases like Ehlers-Danlos syndrome. Typically here, the mid to distal portion of the renal artery is affected, and it shows the characteristic string of beads appearance on angiography with alternating areas of stenosis and dilation. Atherosclerotic stenosis occurs in older patients with cardiovascular risk factors such as diabetes, smoking, or already pre-existing essential arterial hypertension, which is hypertension without a specific identifiable cause, which actually represents the most common form of hypertension overall. So how can renal artery stenosis be treated? Treatment approaches differ between the two types. RAS inhibitors are used cautiously, particularly in unilateral stenosis. For more information on RAS inhibitors and how they work, check out this video. However, caution is needed, since this can result in an AKI. Also, interventional endovascular procedures can be performed. Typically, a catheter is advanced through the femoral artery and guided up through the aorta to reach the renal artery from below. And then, balloon angioplasty is particularly successful in fibromuscular dysplasia, often achieving cure of hypertension in a significant portion of patients. In atherosclerotic stenosis, stent implantation may be needed additionally to balloon angioplasty, as atherosclerotic lesions tend to have elastic recoil and may not respond well to balloon angioplasty alone. So let's summarize. First, renal artery stenosis typically presents with resistant or difficult to control hypertension, particularly with elevated diastolic blood pressure due to a strong and persistent RAS activation. Therefore, it may be accompanied by hypokalemia or metabolic alkalosis in severe bilateral cases. Second, atherosclerotic renal artery stenosis occurs in older patients with cardiovascular risk factors and affects the proximal renal artery near the aortic origin, whereas fibromuscular dysplasia occurs in younger patients, predominantly women, and affects the mid to distal renal artery. Third, duplex ultrasound is the diagnostic method of choice for suspected renal artery stenosis, detecting increased blood flow velocity through the stenotic segment, while CT or MR angiography can visualize the anatomic location and appearance of the stenosis. And fourth, medical therapy with RAS inhibitors, statins, and antihypertensive medications is the first-line treatment in 2026 for atherosclerotic renal artery stenosis, with revascularization reserved for patients with resistant hypertension or worsening of kidney function despite optimal medical management. And lastly, balloon angioplasty is particularly effective for fibromuscular dysplasia and might cure hypertension in many patients, whereas atherosclerotic stenosis often requires stent placement in addition to angioplasty due to elastic recoil of calcified plaques. I hope this video was helpful. Consider subscribing, and I'll see you in the next video.